Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, we are going through the backlog of topics I've wanted to hit, and that allows us, come 2019, to hit all new topics, all new stuff. We will just be flying by the seat of our pants starting in January. But one of those topics I wanted to hit was my Airway buddy, Canadian Airway guru, George Kovacs, had sent me during one of the early Smacks, I think it was Smack Dublin, a incrementalization talk on breaking down the steps of laryngoscopy and tube delivery into the bare minimum incremental steps to allow you to overlearn each of those and therefore become better at the totality. And some of the stuff was a little dated. I had known George had changed a bunch of things in there, so he was kind enough to re-record that lecture for the EMCrit listeners, and that's what you're going to hear today, and it is excellent stuff. And then over the next couple weeks, I have some additional material from George and some of my own thoughts and some videos and all sorts of good stuff that I'll be releasing to really bolster and further the stuff you hear in this video. But just listening to this, I think will give you an approach both to teach the skills of laryngoscopy and tube delivery, as well as if you don't have in your mind a real understanding of the pieces that go into something you may have learned incorrectly in the first place, then this is the place to get it. Now, before we get to that, two conferences to announce. Two conferences. The first has been mentioned, the Reanimate Conference, our ED-ECMO / eCPR / how to manage a cardiac arrest course in San Diego at the end of January. If you're interested in that, go to reanimateconference.com. Now, the docs tickets are almost gone. I don't even know how few are left, but it's not many. So if you're interested in that, go. What has not really been picking up yet because of my lack of promoting it is the non-doc tickets for nurses, advanced practice providers, and respiratory therapists. You are more than welcome. We have a track specifically for you. It's pretty much the same as the regular course with just less of the cannulator hands-on and more of the assistance hands-on. And trust me, if you have eCPR at your shop, whatever your role, you want to be part of this because now you'll finally understand what the hell's going on and could actually take part in the cannulation and initial phases of resuscitative ECMO. So that's reanimateconference.com. The other one being announced for the first time is every January in New York, we do the EMCrit conference. And last year we teamed up with Essentials, which was super fun, but since they have a whole crew, it was not cost effective compared to what we usually do, which is just me doing every bit of work. So we're going back to that. But the format has changed. It now truly is an EMCrit conference. All of the speakers are EMCrit team members. So you have the Josh Farkas, the Rory Spiegel, the Howard Greller, me. And then we'll have a guest of honor soon to be announced. I'm hoping for a certain queen of all things palliative care, but that remains to be seen if we could get that person. But the point is, it's going to be your faves from EMCrit. If you want to hear Josh talk, this is the place to go because he is amazing and he is like really breaking out onto the speaking scene and you want to hear him talk. But this conference is kind of crazy. The format, totally different. We're doing something brand new, something I don't think has ever been done before in the medical sphere. The whole conference, 4-hour conference, with breaks, but 4-hour conference, the long conversation. No lectures, no PowerPoints, no people standing up there alone. It's just going to be 3 people on the stage talking through clinical topics. Now, who those 3 people are will continuously switch off throughout the day. So you might have Josh, Rory, and I at one moment. You might have Josh, Rory, and our guest of honor. It's always going to be shifting back and forth. We'll get the Tox people up there. It's going to be good fun. But it really fits in with the fact that we're all podcasters. And there's no reason for us to be giving lectures when we could do what we're actually good at, which is talking to you. Kind of freeform. We'll have topics planned ahead of time, but we're not going to plan out what we're going to say. We're not going to have dumb slides like locking us into topics. We'll be able to take questions from the audience and use those to mold the conversation. It's going to be super cool. If you're interested in that and you're a New York City resident from a program that's already been contacted, then you already know about this. But if you're not, if you're a resident from an outside program or an attending or a nurse or an APP or a paramedic, come on over to EMCritconference.com, EMCritconference, one word, .com, and buy some tickets. Going by the previous years where we've been selling tickets to outside people, they've gone out within the first week. All gone, no more. Basta. So if you're interested in this, check it out. It's January 9th, New York City. It's good stuff. And let's get right to George Kovacs on the incrementalization of airway management.
It was anyone can intubate or not, and it was about teaching and learning airway management the anti-fragile way. But really, this piece is about how we have a focused, rapidly executable approach to difficulty in managing a patient's airway. So Rich Levin talks about incrementalization, talks about kata and airway kata, and what you're doing is you learn in steps, but ultimately you need to execute as one fluid motion. And I can't tell you how important we think this in, and I use the example often. If I ask somebody to remember 10 digits, they're unable to tell me those 10 digits. However, if I format it, this is a phone number, then they're able to tell me, because that becomes a phone number, as opposed to a series of digits. And in the same way, when we run into difficulty and you only see the epiglottis, you can't refer back to, okay, there are 8 or 9 steps that I'm supposed to do. You need to have trained and practice so that these kata, these individual components, are executed as one. And this is really the topic of this. This is what we refer to as EVLI, or epiglottoscopy, volleculoscopy, laryngoscopy, and intubation, and it works with whatever kind of device that you're using. And this is the way to sort of chunk this material, so hopefully you can execute it when you see something such as an epiglottis only view. And this is, again, how we talk about mental rehearsal. This is going through, I think, the 8 or 9 steps that are involved. And if I practice that on mannequins, or if I just do it the way I'm doing, I can then execute that as one fluid motion without having to think about it. And really, our approach should be that on first attempt, we should have employed all of our optimization maneuvers and not have to go back in a second attempt because we forgot to do one of these things. So that's really what EVLI is. This is what we call system 1 training, or psychomotor rehearsal. We need to learn as many but execute as one. And the problem is that what happens is people, if you go in just looking for the hole, you might get lucky or not, right? So it's not about just going in to do laryngoscopy and then following with intubation. So let's talk a bit more, in a bit more detail, what EVLI means. So it's epiglottoscopy, volleculoscopy, laryngoscopy, and intubation. And let's take you through this. So epiglottoscopy, this is Rich Leviton's term. And you got to go in, looking for your friend. Look for the epiglottis, because if I know where the epiglottis, if I can see the epiglottis, then I know where the glottic inlet is. And there's all kinds of the things that you can do to manage this challenge. But if you don't go in looking for the epiglottis, the problem is that you're going to overrun it. You're going to end up in the esophagus or some other badness. So the epiglottis is sort of the flag when you're playing golf. I'm terrible at golf, but you can't see the hole. But if I see the flag, I know where the hole is, and then hopefully I'm going to be able to take the right shot, choose the right club to get it in there. And that's what epiglottoscopy is, and you should do that regardless of the device you're using, a Macintosh blade or a hyperangulated video laryngoscope. Now, volleculoscopy, it's a bit of a misnomer, because you're not going in to look at the vollecula. Really what I'm talking about is that you have to be careful in seating your blade properly in the vollecula. And we think that that's where the blade should be, whether you're using a Macintosh type device or whether you're using a hyperangulated device, for reasons that I'll talk about later. And this is all about fine motor control. if I go in and I lift prematurely, as you see here, nothing happens to the epiglottis. If I then go down, I engage that hyoepiglottic ligament perfectly, then the epiglottis is going to move out of the way. So again, just to sort of see this again, if you lift prematurely, nothing happens, but again, you put pressure on that hyoepiglottic ligament, then you're going to be able to secondarily lift the epiglottis out of the way and hopefully get that good view. But it is a game in millimeters. So if I go in too proximal, then this happens, what you see in this video. If I go in too far, then I can deflect the epiglottis posteriorly and create a nasty grade 3 or a 3B view. And the most common cause of a 3B view, which is a deflected epiglottis posterior, has nothing to do with intrinsic anatomic or pathologic issues. It really usually has to do with poor laryngoscopy, and it's an iatrogenic issue. So veliculoscopy, as it relates to hyperangulated video laryngoscopy, it relates to being not too close. So the way I can reassure myself that I'm not too close is that the epiglottis is in my field of vision, usually hugging the top of the screen, as you see in the image on the left, right? So my blade tip is anterior to the epiglottis, as opposed to the right-sided image, where I'm posterior to the epiglottis. I've overridden that epiglottis, and I'm sitting actually on top of the glottis and causing all kinds of badness. So veliculoscopy, as it relates to hyperangulated video laryngoscopy, means, again, we think you should be in the blade tip in the vallecula, as that will ensure that you're not too close. Now, from a laryngoscopy, for a Macintosh laryngoscopy, head lift is, I think, the most underutilized bonus that you can bring to the table when you're doing Macintosh laryngoscopy, video or direct. Now, in this image that you see here, what's happening is I'm lifting that patient up from a slightly head elevated position, and so you can do that, and some people will say, and I will often do this, I won't actually adjust my patient's head to a predetermined position before I go in. My right hand moves to the occiput, and then I lift the head to a desired view, and then place blankets or sheets to maintain that view. Now, some people are critical of that, and again, I have no issue with that. But even if you start with a head elevated position or a sniffing position where you've got towels underneath there, don't underestimate the value of further head lift to optimize that view. ELM, as we know, it's about reaching around yourself and trying to manipulate the larynx so that you have an improved view, and then handing that off or guiding the hand of somebody else to maintain that view. So with hyperangulated video laryngoscopy, the key is that you want to align the camera with the long axis of the trachea, as you see in the image below, as opposed to the images on top of this slide, where you're aligned with the anterior aspect of the glottis. So let's talk about the image on top there for a second. So this is too close, right? We know that by the fact that we can't see the epiglottis in our field of vision. So we know our blade is actually riding on the top of the glottis and probably deflecting the larynx superiorly. But I'm actually looking up, as you see on the image on the left upper side. My camera and stuff is looking up at the anterior wall of the trachea. And that little bump that you see the white of the trachea beyond the cords, that little bump is actually the cricoid ring. And seeing the white in that cricoid ring, which Leviton's referred to as the Kovacs sign, I don't care what you call it. Bottom line is that if you see this view where your glottis is occupying the majority of your screen, and you look beyond the cords and you see the white of the anterior wall of the trachea, I think it's a predictor for having difficulty with intubation. And the preferred view is what you see below, where the distal third of your hyperangulated blade and camera is aligned with a long axis of the trachea. So when I look down in that restricted view, really it's derotated. If you compare it to the blade of the video laryngoscope above, you can see it's sort of derotated and placed in the vallecula, so that I'm looking down the long axis of the trachea and I see a black hole, right? That black hole sign is there because rather than look at the anterior wall, I'm looking down the long axis of the trachea, and that's your desired view. This is just an example of what happens if you get too close. I'm probably deflecting the larynx anteriorly, and I'm coming up from posterior to anterior, and my tube will get caught on a cricoid ring in this scenario, but potentially on tracheal rings also. So that was laryngoscopy. Now it's on to intubation. For Macintosh laryngoscopy, you want to have it straight to cuff and at about a 30 to 40 degree bend. And for those non-Canadians, that's actually the angle that a hockey stick is. Unfortunately, people refer to the hockey stick as being this 90 degree bend. But trust me, I've got about 6 or 7 hockey sticks because my kids played, and it's a wonderful game that I continue to play. But a hockey stick is actually a 30 to 40 degree bend. That's what you should be using for Macintosh laryngoscopy. And if you do that, then it should sink fairly easily. Now, the thing I'm going to talk about here is what you see on the bottom video is what you do with a bougie. Now, we all know from the driver study is that there's good evidence to say we should be much more liberal in using a bougie with a Macintosh laryngoscope, video or direct. And they would suggest that you do it on every occasion. And I'm not going to argue with that statement at all. But sometimes you run into a problem when you place a bougie. And in general, when you run into difficulty placing a tube, you're usually working on the right side of the mouth, and then the pharynx, and then the larynx. And the bougie, what happens is the tube gets caught, the leading edge of the bevel is on the right and gets caught on right-sided structures. So with a counterclockwise movement, what you should do is actually bring it back by a centimeter. A counterclockwise movement to the left will take it off of those right-sided structures, and you will relieve that obstruction. Don't do what you see here, which is just rotate it because it gets hung up on the tissue. Come back a little bit, rotate it to the left, or turn counterclockwise, and it'll all be good. This is just another image. This is the classic scenario. We used to teach using a bougie where it's blind, but here what we should do as part of our airway kata or EVLI is that should be our intrinsic motion when we're using a tube over a bougie in the first place. Don't wait for it to be caught up. As your tube is moving over your bougie, move the natural curve of your endotracheal tube to the left or counterclockwise before you hit the laryngeal structures, and you won't meet resistance at all. Just another image here. This is what you should do. Again, this is the desired restricted view. So this is a 50-50 view. And with this view, you shouldn't have a problem in terms of sinking your tube. Now, I will say that when you create a 50-50 or less view, as the tube approaches the glottic inlet, you sometimes can lose your view. At that point, you can do a bit of an aggressive lift, again, to get it to the glottic inlet, and then back it off to that restricted 50-50 view to move the tube down the trachea. All right. So just from a bend point of view, when you're using a hyperangulated video laryngoscope, ideally you want to use the least bend possible. And 60 to 70 degree bend is probably what's optimal. So it's going to be more than what you're going to use with a Macintosh blade. And if you run into challenges, so challenges proximal to the glottis, you're going to rotate your tube to the left. Challenges distal to the glottis, you're going to rotate your tube to the right. And I'm not going to go into this in detail, but what's happening is that the leading edge of the bevel is getting caught on your cricoid ring or tracheal rings, and by rotating it clockwise or to the right, the bevel now faces up, and it takes that leading edge off of the tracheal ring or cricoid ring on which it is caught, and you'll see that in this video here. So again, just with the rotation to the right, that will often take or clockwise, that will take the leading edge off of a ring, and you'll be able to sink that tube. All kinds of people suggesting ways you should bend your styletted tube. The one on the left. I really think that these are just compensating for poor video laryngoscopy. Ideally, you don't want to have any bend in place in the tube. You want to have things on direct vision and boom, sink it right in. But we need to get around structures. So we wanted to use the least possible bend so we don't get hung up anteriorly. And as you see in the right, that's the 30 to 40 degree bend of DL or Mac VL. The one in the middle is the hyperangulated video laryngoscope ideal 60 to 70 degree bend. Again, what people refer to as a hockey stick, which we now know isn't a hockey stick, of a 90 degree bend, I think is compensation for non-optimal VL. And that's it. So that's EVLI, epiglotoscopy, folliculoscopy, laryngoscopy, and intubation. Learn it all incrementally, but practice to execute it as a sequence, as one smooth delivery, so you don't have to think about it each time. So that's all I got to say. See ya.